I'm just running through this post-COVID management. It's based on the latest guideline that was published by Ministry of Health, our Malaysia guideline for post-COVID management. So post-COVID aftercare is with a multidisciplinary approach. And the definition of 3 phases, which include acute COVID-19, which is up to 4 weeks, ongoing symptoms, 4 to 12 weeks, and post-COVID syndrome, we define as symptoms that last more than 12 weeks. All right, so what are the symptoms, possible common symptoms? So ENT, you can find some tinnitus, sore throat, loss of taste, or what, loss of smell, in the respiratory, of course, breathlessness, cough. Your CVS is chest tightness, chest pain, palpitation. GI symptom could be because of your transaminitis, abdominal pain, nausea, diarrhea, anorexia, and reduced appetite. And generally, fatigue, fever, and pain. And neurologically, with a loss of memory, headache, sleep disturbance, and I think insomnia is one of the quite common complaints that we used to see during our TCAs in the hospital. Psychological lines, depression, anxiety, musculoskeletal, and dermatological. All right. So as I said, acute is up to 4 weeks. Okay. Post-acute, and then up to week 12, and chronic or post-COVID syndrome is up to week 12 and above. So after 4 weeks, this studies is done by our site by our TCA COVID. So the 5 most common reported symptoms were fatigue, which is 82%, exertional dyspnea, which is 51%, insomnia, 16%, cough, 11%, and anxiety. So basically, after the 12 weeks, the symptoms are relatively the same: fatigue, exertional dyspnea, insomnia, cough, and also pain. So from this guideline, actually they said that Cat 1 to Cat 3, if you have any symptoms, you should go to the nearest clinic. We should give this advice to the patients. If not, then in certain cases where we have cases where the X-ray actually not quite bad, but patient never desaturated, sometimes you also TCA them to the nearest clinical kesihatan. So for category 4-5, we have our post-COVID clinic by a multidisciplinary team. General physician, respiratory physician usually on Friday, rehabilitation physician, but they usually call over the phone. Unless they find that the patient has some symptom or what, then they might have a TCA, that is physical TCA. And of course, physiotherapy. So important point to note during the TCA when you see the patient, the symptoms must, since we know that it's 4 weeks and then 12 weeks, we don't assume all the symptoms are attributed to COVID. We have to find out other diagnoses. And the main symptoms are usually in between these 4 major systems: respiratory, CVS, PSY, and also neuro. So discuss on how the person's life and activity are affected, and ask whether they are worried or distressed. If there is a new cognitive symptoms, like memory loss or what, you should do an MMSE lah. And also looking at the diabetes, because we are eating a lot of steroid. So some of the symptoms and management lah. So if there is cough and breathlessness, of course the vital signs are done. And some people actually, the guideline actually advocates a 6-minute walking test and a 1-minute sit and stand test, which we actually can't afford to do a 6-minute walking test lah. In the clinic, it's quite busy. But usually we have an X-ray. Otherwise, if the X-ray is not doing too good, or we think that patients might need a HRCT or CTPA or spirometry, do think about other things like possible PE, which may occur after they've been discharged. ABG, if we can, but usually we are not doing ABG because of limitation of the test. And also thinking of rheumatoid factor and ANA and ECHO to rule out other causes of interstitial lung disease, whether it's rheumatological condition related or heart that causes the cough and breathlessness. So, of course, we need to optimize the management of pre-existing respiratory conditions like asthma or COPD, and then consider a respiratory referral and also rehabilitation for pulmonary rehab, we can refer them. If you think a dietitian might help because of the muscle weakness and all, we might also refer to them. So fatigue, second most common symptom, usually we offer some reassurance and tell them self-care, sleep, relaxation, and nutritional therapy, and recommended caution with return to exercise. So just ask them to stepwise increase in terms of exercise, and we can be and this exercise can be supported by physio as well as rehab. All right, chest pain. Chest pain, of course, we do take the vital sign and do an ECG. So what are the possibilities? Of course, need to go out ACS, myocarditis is part of it, and also other causes like pericarditis, arrhythmia, heart failure. And we manage with reassurance. Of course, if let's say the patient has never done any scan before and suddenly complain of pleuritic chest pain, we might also think of organizing pneumonia. And so usually those with myocarditis, they have symptoms up to 36 months. Depression and anxiety, there are a lot of scoring, DAS 22, 21 or GAD scoring, but the scoring is very panjang. So I didn't put it in. I choose one of the questions that is simple, and I think we can adapt that into our COVID screening question when we see the patient in post-COVID clinic. Of course, we need to assess of multifactorial contributors that may require assistance, like money, moral support, social support, and referring to the supportive team. So these are the questions. It's called Buloh question. It's actually ada rasa menolong sedih atau tiada harapan, yes or no, kurang minat. It's only 2 questions, so it's easier. This is the anxiety scoring. So do you feel nervous? Do you feel worry or relaxation and all? So of course, after doing it, we are also referring to the psychiatry or psychology. So NMRC scale for dyspnea and also post-COVID functional scale, these are the symptoms that you might want to run through fast during your TCA COVID. So if they have symptoms, what are the symptoms? Breathless, fatigue, cough, nausea, anosmia, nightmares, these are the PSY symptoms, and also mainly are the all this. So this is the algorithm for stage 3. So for our stage 3, so like our GGO and all, follow up after discharge 12 weeks is advisable, but we are not doing it because there's actually too many stage 3. Don't know whether the KK can actually cope with it or not. So a full clinical assessment and repeat an X-ray. Unless you see the X-ray is really bad, maybe you should refer to them as a follow-up. So if persistent and progressive symptoms, of course, you will do an X-ray. You will refer to stage 4 and 5. I'll show you this. If no, then you do an X-ray. If the X-ray resolution, of course, you can discharge. I hear someone talking. Is it someone talking? I'm not sure. Yeah. So follow up for CAT 4 and 5. So after 4 weeks, we usually give them a TCA, which is full clinical assessment. Of course, it is a multi-system approach, and then repeat X-ray we usually do, and we do an exertional test. Actually, the exertion test we don't do in our clinic, but we only do our SpO2 and all. Maybe you can consider this 1 minute sit and stand. So after that, if there is any abnormal X-ray and physiological impairment, we should do a HRCT and CTPA, consider echo and pulmonary function test. And we are looking for whether there are worsening of interstitial lung disease or actually a cardiac cause or PE basically. And then you refer to respiratory physician accordingly. If the X-ray there's some residual changes, but symptoms improve, no physiological impairment, you can repeat the X-ray in 3 months' time. And then same thing, whether there's any interstitial lung disease or PE or not. And then refer to the rehabilitation, physio and rehab, pulmonary rehab also. So these are the ones that with organizing pneumonia. So organizing pneumonia, we also, so initial CRS and then responding to treatment, or subsequently we did a scan, we diagnosed the organizing pneumonia, as most of our cases are. Whether we give metapred or prednisolone, we discharge them and we follow up them 4 to 6 weeks. So this clinical first assessment is X-ray, and also of course we really need to watch out for the side effect of the steroid, including sugar, BP. A lot of patients they might appear Cushingnoid, or they can't sleep. A lot of side effect from the steroid, or infection. So we have to follow up here. Subsequently, by right, they are supposed to have a follow up at week 12 of discharge, just to make sure it's a full functional test with X-ray, lung function test, and 6-minute walking test. This one is usually done in our UITM. Of course, if normal discharge, if not normal, then we'll proceed with other CTPA or CT thorax. So the prednisolone, there is a star here. As we know that we are aiming lower dose nowadays because of the side effect. So it's 0.5 to 1 mg per kg, maximum 60, and then taper every 5 mg every 5 days. So it should be commenced after ruling out significant infection, like PEP. Okay. So for respiratory test follow-up, right, this, according to the guideline, we should do it like a baseline for the first appointment, 6 months and 12 months for spirometry and 6-minute walk test, which we didn't do for this. Usually we don't order a spirometry, or we don't really do a 6-minute walking test in our TCA COVID, but this is allocated in the guideline. So I just want to put in this why we are doing ABG during TCA. So actually just to see whether LTOT would be beneficial for the patient, because a lot of people that we discharge with SpO2 of 88 and all, maybe they cannot tahan. So maybe you want to consider doing ABG for those very low SpO2 during the TCA. So the general indication for long-term LTOT, the PO2 has to be less than 55. In the presence of cold pulmonary is 59. And then other indication is evidence of P pulmonary, hematocrit more than 55%, or evidence of right heart failure. So PO2 of other conditions like more than 60, if there is lung disease or also sleep apnea. Or if all patient needs all these, then we might also offer this LTOT. So this is that's all for my general approach of post-COVID management.